Welcome to the Hospital Medicine Unplugged podcast. Today we're kicking off a really high-yield deep dive into cerebral venous sinus thrombosis, that's CVST. It's definitely one of those conditions that can be a major diagnostic and, well, therapeutic headache for us hospitalists and anyone working in acute care.
It really is. CVST, it's often called a diagnostic chameleon for a good reason. It can mimic almost anything from a bad migraine to an arterial stroke.
Exactly.
So our mission today for you listening is to provide a structured, evidence-based roadmap. We synthesized information from really the best sources out there. We're talking the American Heart Association and CHEST guidelines, major clinical reviews from top journals like the NEJM and JAMA. The goal is to distill all that down into actionable clinical insights.
And we'll be focusing on providing clarity on the pathophysiology, what's actually happening. We'll hone in on the diagnostic strategy and, maybe most critically, get into mastering the acute and long-term management. We absolutely have to tackle that really high-stakes clinical decision, when and importantly, why you initiate full-dose anticoagulation. Even if the initial scans show some bleeding, that's where, clinical confidence is everything.
Absolutely. So let's just dive right in. We should start where all good management really begins, understanding the mechanism of injury.
Okay, let's unpack this unique type of stroke then.
Yeah.
So CVST, by definition, it's thrombus formation, a clot in the dural venous sinuses or the cerebral veins themselves. Now, unlike an arterial blockage, which immediately cuts off the oxygen supply, venous thrombosis causes neurological damage through sort of a two-pronged mechanical issue. It's all tied to impaired venous drainage.
That's right.
First off, the clot leads to a rapid increase in intracranial pressure, ICP. See, the dural sinuses are the main drainage paths for cerebrospinal fluid, the CSF, via structures called arachnoid granulations. So when that outflow gets blocked by a clot, CSF absorption just tanks. It gets severely impaired. This causes congestion, pressure backup, and clinically, that's where you see that classic trio.
Yeah.
A really severe progressive headache, papilledema, the swelling of the optic nerve head, and sometimes a non-localizing sixth nerve palsy, just from the pressure on the nerve itself.
And the second prong, that's the focal brain injury. Now, this isn't from a lack of arterial blood coming in. It's actually the backup of venous blood causing severe congestion. Think of it like a traffic jam. This high pressure forces fluid out of the blood vessels, leading to what we call vasogenic edema. Now, if that pressure is severe enough and hangs around long enough, it leads to ischemia and eventually venous infarction. And crucially, this is really key, these venous infarcts are highly prone to hemorrhage. They rupture easily because of that underlying congestion and high pressure. So you often see intracerebral hemorrhage right within the infarct zone itself.
And why is that distinction, venous hemorrhage versus arterial hemorrhage, why is that so critical for the hospitalist managing the patient?
Because it fundamentally changes how we approach treatment. It's a different paradigm. See, with arterial strokes, if there's associated hemorrhage, that usually signals advanced, often irreversible tissue damage. Anticoagulation is generally a no-go.
Right, contraindicated.
Exactly. But the tissue damage from a venous infarct, even if it's hemorrhagic, is potentially reversible. Our goal is actually to restore that venous outflow. That's why aggressive, timely anticoagulation is so effective and, frankly, vital, despite seeing blood on the scan. We're essentially treating the cause of the hemorrhage, that congestion, by trying to dissolve the clot that started it all.
That distinction really provides the clinical rationale we need to act decisively, even when it feels a bit counterintuitive.
Okay, so moving from the mechanism to, well, who gets this? Patient selection. You mentioned that something like 70% to 80% of CVST patients have at least one identifiable risk factor. So that means if we see a patient with suggestive symptoms, our next step is immediately screening for these predisposing conditions, right?
Exactly right. We typically categorize these risk factors into several broad domains. Let's start with the inherited prothrombotic conditions. These are pretty common in the CVST population. You have things like factor V Leiden, which significantly boosts the risk. The odds ratio can range anywhere from, say, 2.5 to over 10, depending if someone's homozygous for it. We also look for the prothrombin gene mutation, G22A it's called, and then deficiencies in the body's natural anticoagulants, things like protein C, protein S, and antithrombin deficiency. These conditions basically set the stage for thrombosis because there's a fundamental defect in how the body breaks down or controls clot formation. And then there's a major non-genetic driver, particularly relevant for younger patients, and that's hormonal exposure. The data here is pretty stark, isn't it?
It really is compelling. Estrogen-containing oral contraceptives, for instance, they increase the odds of CVST by nearly 8 times. That's significant.
Wow, eightfold.
Yeah, but the absolute peak risk, that occurs during the postpartum period. The physiological changes of pregnancy, especially that hypercoagulable state combined with some venous stasis, mean the risk jumps over 11-fold compared to baseline. And this risk often peaks in those first few weeks, right after delivery.
So OCPs and postpartum state, huge risks.
Huge. Then we need to focus specifically on the hospitalized patient's unique risk profile. Systemic risks include things like malignancy, especially hematologic cancers like myeloproliferative disorders, though solid tumors certainly contribute too, and also specific autoimmune or inflammatory conditions, maybe like systemic lupus or inflammatory bowel disease. These create a sort of chronic hypercoagulable state.
Infections are another important trigger, often quite localized, right? Like sinusitis.
Exactly. Think about acute bacterial sinusitis or otitis, mastoiditis. These local infections can directly spread inflammation and thrombosis to the adjacent dural sinuses. That can lead to what's called septic CVST.
Yeah.
And finally, we have the iatrogenic risks, things related to medical care and circumstantial hospital risks, prolonged immobilization, a recent major surgery, any significant head or neck trauma, and critically important, the presence of central venous catheters, especially if they're in the internal jugular vein. These are all well-known contributors. These factors tend to promote stasis or maybe cause local vessel wall injury, and that just tips the patient towards thrombosis. So recognizing this whole constellation of risks in a patient who presents with a new, maybe unusual headache on the hospital floor, that should immediately raise your index of suspicion.
That leads us perfectly into the clinical presentation itself. You called CVST a chameleon earlier, and that variability, I think, is what makes the diagnosis so tough. What are the most reliable clinical signs or symptoms we should really be looking for?
Well, the most frequent symptom by far, seen in almost 90% of cases, is headache. And it's usually not subtle. It tends to be diffuse, progressive, often described as being refractory. It just doesn't respond well to typical pain meds.
Right.
We need to be really vigilant for that headache that changes character or severity in a patient who otherwise seems stable. Now, while it's rare, we're talking less than 5%, it can present as a thunderclap headache. That demands immediate differentiation from a subarachnoid hemorrhage, of course.
What's really interesting and sometimes misleading is that the headache can actually be the only symptom, right?
Yeah.
Especially if the thrombosis is maybe milder or just in smaller sinuses.
Absolutely. Isolated headache occurs in up to a quarter, maybe 25% of presentations. So you can't dismiss it just because there aren't other focal findings initially. Beyond the headache, we look for focal neurological deficits. These pop up in about 20% to 50% of patients. Deficits like hemiparesis, aphasia, but they often fluctuate, or they show a pattern that doesn't quite fit a typical arterial territory. That inconsistency should really make you think venous.
Another really critical differentiating symptom seems to be seizures. They're quite characteristic of CVST.
Very characteristic. Seizures occur in 20% to 40% of cases right at presentation. That's significantly higher than you typically see in an arterial stroke. So when a patient presents with new onset focal seizures, particularly if they don't have a clear history of epilepsy, CVST has got to be high on your differential diagnosis list.
And in the more severe cases, what does that look like?
In severe presentations, especially if the deep venous system is involved, we're talking about veins like the internal cerebral veins or the straight sinus, the resulting bilateral thalamic edema can cause things to go downhill very quickly. You can see global encephalopathy, altered mental status, even coma in up to 20% of patients. This presentation demands immediate attention and aggressive management, usually in an ICU setting.
Okay, so given this highly variable clinical picture, imaging obviously becomes indispensable. In the ED, the non-contrast head CT is usually the first test people get. What's its utility, but also what are its major limitations here?
Right, the non-con CT. Its utility is mainly for rapid exclusion of other big things.
Right.
Major hemorrhage, obvious mass lesions, large arterial territory infarcts. You rule those out quickly.
Okay.
Its limitation, though, is profound for CVST specifically. Non-contrast CT is only abnormal in about 1/3 of actual CVST cases. It's just not sensitive enough. You might see some indirect signs, like the dense vessel sign, that's a hyperdensity in the affected sinus from the clotted blood itself, or you might see signs of a hemorrhagic venous infarct. But if that non-contrast CT is negative, you absolutely cannot stop there if you suspect CVST.
So if the CT is negative, or maybe equivocal, what's the next practical rapid step? Especially thinking about hospitals that might not have MRI readily available 24/7.
Yeah, that's a great point. CT venography, or CTV, is a fantastic, rapid, and often much more accessible alternative. The American College of Radiology guidelines actually endorse CTV as being highly sensitive and specific for CVST. It involves injecting IV contrast and then timing the scan to visualize the venous anatomy specifically. It shows thrombi as filling defects, that classic sign people talk about, the empty delta sign in the superior sagittal sinus, that's seen on CTV. It's basically pathognomonic. When you see it, it shows the contrast flowing around the central clot, forming a sort of empty triangle.
Okay, CTV is a great option, but the gold standard still involves MRI, right? MRI with MR venography.
Yes, that combination MRI of the head, both with and without contrast, paired with MR venography or MRV, that remains the gold standard diagnostic approach. Specifically, contrast-enhanced MRV is considered the most accurate method. It's particularly good at differentiating a true thrombus from things that can mimic it, like slow blood flow artifacts or maybe a congenitally small hypoplastic sinus. Those can look like occlusions on non-contrast sequences sometimes.
You mentioned earlier detecting subtle thrombi, maybe in smaller cortical veins. How do we pick those up if they're hard to see?
That's where the more advanced MRI sequences really shine. We're talking about sequences like gradient recalled echo, often called GRE, and susceptibility-weighted imaging, or SWI.
Okay.
These sequences are exquisitely sensitive to the presence of iron, which is found in blood products, so they allow us to detect tiny clots or blood breakdown products within small cortical veins that your standard T1 or T2 weighted images might completely miss. For a hospitalist interpreting these MRI reports, it's really important to be aware of the utility of these specific sequences for catching those subtle findings.
Right, good point. Okay, shifting from imaging to the essential lab workup. The AHA guidelines seem pretty clear on the initial requirements. Beyond the basics, a CBC, a comprehensive coag profile, so a PT and APTD D-dimer testing comes up a lot. What's the actual role of D-dimer here?
D-dimer is actually highly sensitive in acute CVST, with sensitivity reported up to 94%. This makes it potentially a very good rule-out test, but only in a low-probability patient presenting with something like an isolated headache, and importantly, if their symptoms are acute, meaning within the first 7 days or so.
Okay, so there's a big caveat there.
A huge caveat. Its sensitivity drops off significantly in subacute or chronic presentations, say, if symptoms have been going on for weeks, or in cases where the thrombosis only involves isolated cortical veins. Therefore, the critical point is, a normal D-dimer in a patient you have high clinical suspicion for should not deter you from pursuing definitive imaging like CTV or MRV. You can't rely on it alone in that situation.
Got it. That's a really important clinical pearl. And regarding thrombophilia screening testing for those inherited clotting disorders, the question always is, when's the best time? Do we do it right away when we make the diagnosis?
It's generally recommended not to do the comprehensive thrombophilia screening right in the acute phase. The best time is usually after the acute phase has resolved, and ideally after the initial period of anticoagulation is complete.
Why is that?
It's critical because the acute thrombosis itself, especially if it's a severe event, can actually cause a temporary consumption coagulopathy. For example, levels of protein C and protein S, those natural anticoagulants, can be acutely consumed during the clotting process, so they might test falsely low, making it look like the patient has an inherited deficiency when they actually don't.
Oh, okay.
Testing acutely really risks confounding the results and could lead to misclassifying the patient's long-term risk profile. It's better to wait until things have stabilized.
Makes sense. Before we jump into management, let's quickly map out the differential diagnosis. What are the key conditions we absolutely must rule out, especially the really dangerous mimics?
Okay, top of the list, especially for headache and maybe signs of increased ICP, are conditions like migraine, idiopathic intracranial hypertension IIH, and of course other types of stroke like arterial ischemic stroke or intracerebral hemorrhage from non-thrombotic causes like hypertension. Then you have the immediate life-threatening mimics that demand urgent action. Subarachnoid hemorrhage, or SAH, which often presents with that thunderclap headache we mentioned, and acute bacterial meningitis. This is especially relevant if the patient has a potential local source of infection, like that complicated acute bacterial sinusitis we discussed earlier. Imaging, and sometimes performing a lumbar puncture for CSF analysis, are absolutely essential to definitively rule out SAH and meningitis. You need to secure the CVST diagnosis before you start aggressive treatment like anticoagulation.
All right, now we're getting into maybe the highest stakes part, acute management. We've established that the overall prognosis can be really good if we act quickly. So what is the absolute non-negotiable first step we must take once the diagnosis is confirmed?
The immediate, potentially life-saving intervention is the prompt initiation of full-dose systemic anticoagulation. This is truly the bedrock of acute management. It's supported definitively by all the major guidelines: AHA, the European Stroke Organization, EO, CHEST guidelines. Everyone agrees. We need to start full-dose therapy as soon as we have that radiological confirmation of CVST. No delay.
Okay, full dose right away. And in terms of which agent to use, we often see debates between unfractionated heparin drips versus low molecular weight heparin injections. Any preference?
Generally, low molecular weight heparin LMWH is preferred in the inpatient setting for most patients. LMWH offers several key advantages. It has predictable pharmacokinetics, which means we can usually use fixed-dose subcutaneous administration, making it easier to manage.
Right, no frequent PTT checks.
Exactly. Reduced need for that intensive lab monitoring compared to a continuous unfractionated heparin infusion. And importantly, there's a lower risk of developing heparin-induced thrombocytopenia, or HIT. Now, unfractionated heparin is still effective, and it's actually mandatory for patients with severe renal impairment, where LMWH dosing gets really complex or contraindicated. But for most others, LMWH typically serves as the first-line choice.
Okay, LMWH preferred generally. Now let's confront that major point of anxiety for any hospitalist. The imaging confirms CVST, but it also shows a significant intracerebral hemorrhage, that hemorrhagic venous infarct we talked about. Do we still pull the trigger on anticoagulation?
Yes, emphatically yes. The guidelines are absolutely clear and definitive on this point. Full-dose anticoagulation must be initiated, even in the presence of intracerebral hemorrhage. This is a critical departure from how we manage arterial hemorrhagic stroke, and it's entirely dictated by that unique pathophysiology of CVST we discussed earlier.
Can you just reiterate the core clinical thinking behind that? Why aren't we overly worried about making the existing bleed worse?
Well, we are worried, but we're more worried about preventing further venous outflow obstruction. That's the greater danger here. If we withhold anticoagulation, the clot is very likely to propagate, to get bigger, which will worsen the venous congestion. And remember, that congestion is what's causing the brain to swell and causing the hemorrhage in the first place.
Oh, okay.
By initiating anticoagulation, our goal is actually early recanalization, opening up that blocked sinus. This improves venous outflow, reduces the congestion, and paradoxically, we think it limits the risk of further secondary hemorrhagic injury or expansion of the existing bleed. While randomized trial data is somewhat limited, the available evidence suggests that starting anticoagulation doesn't significantly increase the risk of symptomatic worsening of the hemorrhage or cause new clinically significant bleeding. The bottom line is, the risk of the thrombus extending and causing more widespread damage outweighs the perceived risk of anticoagulating an existing bleed in this specific context.
That is such an essential message for everyone managing these patients to internalize. Okay, but there are specific situations where heparin is absolutely forbidden, right?
Precisely. If we suspect or confirm heparin-induced thrombocytopenia, HIT, heparin in any form is contraindicated, or if the patient's CVST is related to that very specific rare mechanism of vaccine-induced immune thrombotic thrombocytopenia, VITT, again, heparin is off the table.
So what do we use then?
In those cases, we absolutely must use alternative non-heparin anticoagulants. For acute treatment in the hospital, this often means using direct thrombin inhibitors like IV ergotrobin or maybe bivalirudin. For VITT specifically, the management is highly specialized. It often involves not just a non-heparin anticoagulant like a DOAC or ergotropin, but also concurrent use of high-dose intravenous immunoglobulin, IVIG. The IVIG is thought to help disrupt the pathogenic antibodies involved. It's a complex situation requiring specialist input.
Right, very specialized. Okay, moving on to supportive care measures. Seizures are common, as we noted. What's the guideline stance on giving prophylactic anticonvulsants to everyone with CVST?
Routine prophylactic use-giving anticonvulsants, just in case, is explicitly not recommended by the guidelines. Anticonvulsants should only be initiated therapeutically, meaning after a first seizure has actually occurred. Or perhaps in certain high-risk patients who have substantial documented parenchymal lesions, like a large venous infarct seen on imaging. Those lesions act as a high-risk focus for future seizures, so prophylaxis might be considered there, but not routinely for everyone.
Okay, treat seizures when they happen. Don't prevent them routinely. What about managing raised ICP? This is where acute care docs often feel the pressure to intervene. Our instinct might be to reach for things like glucocorticoids, steroids, or diuretics like mannitol or acetazolamide. What do the guidelines say about that?
Yeah, it's counterintuitive again. The guidelines actually recommend against the routine use of these medical therapies. Steroids, acetazolamide, mannitol for generalized raised ICP specifically associated with CVST. Glucocorticoids in particular are specifically discouraged for the cerebral swelling in this context. There's just no proven benefit, and there are potential risks, like infection. Furthermore, diuretics like acetazolamide, which are sometimes used for idiopathic intracranial hypertension, IIH, are generally discouraged in CVST. There's a theoretical concern that inducing dehydration and reducing plasma volume could actually increase blood viscosity and promote a prothrombotic state, potentially making the underlying venous clot worse.
So if medical ICP management like steroids and diuretics is generally discouraged, monitoring becomes even more critical. Where should these patients ideally be managed?
They really should be managed in a dedicated stroke unit or an intensive care setting, somewhere that allows for frequent, scheduled neurological assessments. Rapid detection of any decline in consciousness or worsening focal deficits is absolutely essential. Deterioration might signal the need for urgent escalation to those advanced or even surgical therapies we'll discuss.
Right. And to help structure that monitoring and maybe provide some prognostic clarity, we can turn to severity tools. Let's focus on one key one, the CVT grading scale, or CVT-GS. What makes this scale clinically useful for the team at the bedside?
The CVT-GS is really useful because it provides a rapid, pretty objective way to stratify a patient's risk of having a poor outcome, defined as dependency or death within the first 30 days. And it uses readily available clinical and radiological markers that you usually know early on. Key components include objective measures of the neurological injury itself, like the size of any parenchymal lesion. Specifically, there's a poor prognostic cutoff if the lesion is greater than 6 centimeters in diameter.
Okay, size matter.
Size matters. Also, the patient's baseline level of consciousness is a major factor, and the presence of bilateral Babinski signs indicating significant corticospinal tract involvement. Interestingly, male sex is also consistently included in these scores as a risk factor for a worse outcome. The exact reason why is still debated, but it suggests maybe some underlying physiological differences in how CVST presents or how patients respond to it.
So what's the real-world impact of using a score like this?
Yeah.
How big is the difference in prognosis between, say, the mild and severe categories?
The difference is profound, and that's why it's so clinically useful. A patient who falls into the mild category, scoring maybe 0 to 2 points on the scale, generally has an excellent prognosis. Their estimated 30-day fatality rate is very low, around 0.4%.
Wow, very low.
Very low. Now, contrast that starkly with a patient in the severe category, someone scoring 8 to 13 points. Here, the 30-day fatality rate skyrockets to about 61.4%.
Over 60%. That's a massive difference.
A massive difference. So this tool is really essential for guiding clinical decision-making. It helps with things like resource allocation, deciding if a patient needs transfer to a specialized comprehensive stroke center, or maybe initiating earlier discussions about the potential need for more advanced interventions if they're already scoring in that severe range.
That leads us directly into the next question. Escalation of therapy. We've started the patient on full-dose LMWH. They're being monitored closely, but they continue to deteriorate neurologically. That's the definition of refractory CVST.
Yeah.
What advanced therapies are actually available then? And maybe more importantly, what does the evidence really tell us about whether they work?
Right. So when standard medical therapy fails, and the patient's neurological status is clearly worsening despite adequate anticoagulation, that's when we reserve endovascular interventions. These typically fall into two categories. Local catheter-directed thrombolysis, which means injecting clot-busting drugs like TPA directly into the blocked sinus via catheter, or mechanical thrombectomy, which involves using devices threaded up through the veins to physically pull out or break up the clot.
Now, endovascular therapy like thrombectomy is pretty much standard of care now for acute arterial stroke, large vessel occlusion. Is the data just as strong for using it in CVST?
This is a really critical distinction we need to make. The data for using these interventions in CVST is far weaker, much less robust than for arterial stroke. And the consensus for when to use them is much, much narrower. There have been trials, like the DOACs trial, for example. They did show that these endovascular interventions do increase the rate of achieving complete venous recanalization, opening up the sinus, compared to just standard anticoagulation alone.
Okay, so they open the pipe better.
They seem to open the pipe better, yes. However, and this is the crucial part, the procedures themselves were also associated with higher rates of complications, specifically intracranial hemorrhage related to the procedure. And most importantly, They did not consistently demonstrate an improved functional outcome for the patient at, say, 6 or 12 months.
Wait, so if the recanalization rate is better, they open the sinus more often, why isn't the functional outcome better? That seems quite counterintuitive and really demands a critical look.
It absolutely does, and it's sort of the prevailing paradox in the field right now. The leading hypothesis is probably twofold. First, that increased risk of complications, particularly procedural bleeding or maybe vessel injury during the thrombectomy, might simply negate any potential benefits gained from faster recanalization.
Okay, the risks outweigh the benefits potentially.
Potentially. And second, it might be that in CVST, the ultimate tissue damage isn't solely driven by the acute lack of venous outflow at the moment of intervention. It might be more influenced by the severe edema and congestion that occurred before the intervention could even happen. This could lead to tissue damage that's already somewhat established and maybe less responsive to just immediate reperfusion compared to arterial stroke. So for these reasons, endovascular therapies remain pretty restricted. They should generally only be performed in specialized centers with significant expertise and really only considered for the most severe, refractory, life-threatening cases where the patient is clearly declining rapidly despite optimal medical management with anticoagulation.
Got it. Reserved for the worst cases. And in that truly catastrophic situation, say a massive venous infarct leading to malignant cerebral edema, the brain is swelling rapidly and the patient is at risk of herniation, is surgery the only option left then?
That's right. In that dire circumstance, decompressive hemicraniectomy, essentially removing a large piece of the skull to allow the swollen brain to expand outwards, remains the final, necessary surgical salvage option. For carefully selected patients who are deteriorating rapidly because of uncontrolled intracranial hypertension and are at imminent risk of brain herniation, observational data does suggest that this procedure can be life-saving. And importantly, it can improve the odds of achieving functional independence down the road compared to just continuing medical management alone in that specific scenario.
Okay, a life-saving last resort. Assuming we successfully stabilize the patient through the acute phase, the next major step is planning the transition from parenteral heparin, like LMWH, to long-term oral anticoagulation for discharge. What are the modern options there?
So the transition traditionally involves starting a vitamin K antagonist, or VKA, which for most people means warfarin. You'd overlap it with the heparin until the INR was therapeutic.
Right, the warfarin bridge.
The classic warfarin bridge. However, we now have really good data from landmark trials, probably the most important being the ORSPECT CVT trial. These trials have established the direct oral anticoagulants, the DOACs like dabigatran, rivaroxaban, apixaban, edoxaban, as safe and effective alternatives for long-term therapy after CVST. Current data indicates that DOACs offer comparable efficacy to warfarin in preventing recurrent VTE, including recurrent CVST.
And are there advantages to using DOACs?
Yes, often with the added benefits we see in other conditions. Easier use, fixed dosing, no routine INR monitoring, fewer dietary and drug interactions compared to warfarin, and in some studies, potentially a lower risk of major hemorrhage, especially intracranial hemorrhage. So this makes DOACs a favored choice now for many hospitalists and neurologists when planning long-term anticoagulation after CVST.
That brings us to probably the most practical and frequent question we get asked during discharge planning. How long does the patient actually need to stay on this oral anticoagulant?
Right, the duration question. It's highly individualized. The duration is determined almost entirely by the patient's underlying risk factor profile, and we're guided here by the recommendations from the AHA and CHEST guidelines. So if the CVST was clearly provoked by a transient or reversible risk factor, think about the patient who is on estrogen-containing OCPs and stopped them, or someone who had recent major surgery, or a self-limiting infection that's now treated. In those cases, the standard duration of anticoagulation is typically 3 to 6 months.
Okay, 3 to 6 months for provoked cases.
That gives the body enough time for the venous system to stabilize and recover while the transient risk factor is gone.
But what about those patients we identified earlier who have those persistent, ongoing risk factors? The ones that aren't going away?
Exactly. For patients who have persistent, non-transient risk factors, anticoagulation is usually much longer, often indefinite or lifelong. This includes patients with high-risk inherited thrombophilias, maybe homozygous factor V Leiden or antithrombin deficiency, also patients with active malignancy, particularly if it's ongoing or metastatic, or patients who have already had a history of recurrent venous thromboembolism, VTE, even before the CVST event.
Right.
In these situations, the goal shifts to long-term secondary prevention because their underlying predisposition to clotting remains active.
That makes sense. Now, we also need to touch on the role of follow-up imaging. Let's say we repeat an MRV or CTV at 3 or 6 months, and it shows the affected sinus has completely recanalized, looks totally normal. Does that change the decision about anticoagulation duration? Can we stop it early then?
No. This is a really critical teaching point that often causes confusion. The degree of venous recanalization that you see on follow-up imaging should not be the primary factor guiding the duration of anticoagulation.
Really? Why not?
Well, while recanalization is certainly common after treatment, and it's good to see, studies have shown that it doesn't reliably predict clinical outcomes or the future risk of recurrence. Some patients have persistent occlusion but do fine, while others recanalize fully and still have a recurrence later if their risk factor persists. So the decision about duration must be based almost solely on that clinical risk factor profile we just discussed. Was it provoked by something transient, or is there an ongoing risk? Don't let the imaging alone dictate stopping therapy if an ongoing risk factor is present.
That's a very important clarification. Okay, finally, let's try to provide a realistic picture of the prognosis and look at the long-term sequelae, the after effects. The statistics often sound quite favorable overall, but what does that favorable outcome actually look like in real life for these patients?
Yeah, it's important to be realistic but also reassuring. Overall, the prognosis for CVST is generally favorable, especially compared to severe arterial strokes. This should be emphasized to the patient and the hospital team. Approximately 80% to 90% of patients will achieve functional independence, which is usually defined by a modified Rankin Scale score, or MRS, of 0 to 2. That means minimal or no disability in daily activities.
Okay, 80–90% functionally independent sounds good.
It does sound good. However, we absolutely must acknowledge the 10% to 15% minority who unfortunately experience death or significant long-term dependency, an MRS score of 3 to 6. And we know some predictors for this poorer prognosis. These include things like advanced age, the presence of an active malignancy, a significantly decreased level of consciousness when they first presented, and importantly, involvement of the deep venous system thrombosis in veins like the straight sinus or internal cerebral veins tends to carry a worse prognosis.
But even for that large majority, the 80–90% who achieve that technical, functional independence, there seems to be a quieter, often quite debilitating long-term impact that maybe gets missed in standard follow-up.
That is the crucial and I think often overlooked layer of long-term morbidity. You're absolutely right. Despite achieving a physically good outcome based on the MRS scale, studies suggest that up to 40% of CVST survivors may struggle significantly to return to their previous level of work or daily activity. This is often due to persistent residual symptoms that aren't necessarily disabling in terms of basic ADLs, but deeply impact quality of life. These chronic sequelae include things like persistent, often daily, chronic headache, profound fatigue that doesn't resolve, significant cognitive impairment trouble with memory, attention, executive function, often called brain fog, and mood disturbances like depression and anxiety are also very common.
So a good outcome on paper doesn't always mean a full return to their previous life.
Exactly. It doesn't always mean a full return to baseline quality of life or functional status in the broader sense. Now, on the slightly brighter side, the risk of CVST itself recurring is relatively low, generally estimated at less than 2% per year after the initial event, especially if anticoagulation is managed appropriately. However, these patients do remain at a persistent, elevated risk of developing other types of venous thromboembolism, VTE, elsewhere in the body, like a DVT or PE. That risk is estimated around 1% to 4% per year, which is still significantly higher than the general population. #tag outro. Okay, so to try and synthesize this complex deep dive into CVST, maybe we can reiterate 4 core clinical imperatives for you, the hospitalist or acute care provider listening. 1. Maintain a high index of suspicion. Any patient presenting with a new severe headache, maybe focal deficits or new seizures, especially if they have known risk factors like recent infections, surgery, hormonal exposures, or malignancy, that combination mandates immediate investigation for CVST. Don't dismiss it.
Right. Think CVST.
2. The absolute cornerstone of acute therapy is prompt, full-dose anticoagulation, generally preferring LMWH for most patients. And remember the key point. This must be initiated even in the presence of intracerebral hemorrhage on imaging. You have to understand this is a unique venous pathology where restoring outflow is paramount.
Critical point.
3. Escalation to more advanced therapies, like endovascular procedures, is strictly reserved for that small subset of refractory cases who are clearly deteriorating clinically despite adequate anticoagulation. This is because of the higher procedural risks and the still uncertain benefits regarding long-term functional outcomes.
Use it sparingly.
Use it very sparingly and in specialized centers. And 4, long-term management typically involves transitioning to oral anticoagulation, with DOACs now often favored as a safe and effective alternative to warfarin. The duration is highly tailored to the individual's risk profile, usually 3 to 6 months for transient or provoked triggers, but extending indefinitely, potentially lifelong for those with persistent high-risk conditions or recurrent VTE.
Excellent summary. So as we conclude this deep dive today, let's leave you, our listeners, with maybe a point for further reflection. We've heard that 80% to 90% of CVST patients achieve good physical outcomes, a good MRS score. But we also heard that a significant proportion, maybe up to 40%, are left struggling with these debilitating chronic symptoms, things like severe fatigue, cognitive impairment, chronic headache. So the question to ponder is, how should our standard hospital discharge planning, our patient education efforts, and maybe our long-term neurocognitive follow-up care need to evolve? How can we better screen for and proactively address these subtle but incredibly significant neurocognitive and psychosocial sequelae? Because really, a good functional outcome has to be more than just the ability to walk or perform basic tasks. It's ultimately about the ability to live a full, meaningful life. Something to think about.